skull-based surgery, went back to Brazil. Now he does a great job in Minas Gerais, one of the states there. But more importantly, Lucas is worried about the development of countries that have more difficulties. So he performed an amazing study that he would explain to you all. And so it's our honor to have Lucas here to participate on this panel and give us his perspective on the development of skull-based surgery around the world, particularly Africa and South America.
Thanks, Professor. It's an honor to be here with you. I'd like to thank Dr. Adil, Dr. Abdelbar, and it's a pleasure to be here with Claire. I admire her work, and to be here with Mikhail. Mikhail is my friend. We have projects together. I'm very happy to be here. So let's share my screen. Just a minute. Okay, can you see it? Okay,
perfect.
So I'm going to talk a little bit about the scenario and challenges of skull-based endoscopy in Latin America. So I want to show just a little bit about our experience, and then the most important would be to discuss the thoughts we have now, the projects we want to run, and we need help. So I hope you can suggest something and help us to have this done in the future. So I have no conflicts of interest to disclose. This is my city. I live in Belo Horizonte, in the state of Minas Gerais, Brazil. Belo Horizonte has the third largest metropolitan region in Brazil after São Paulo and Rio. So we treat about 6 million people here in Belo Horizonte. I made my training, my medical school here in Belo Horizonte, and then neurosurgical residence also here in the hospitals Felício Roxo and João 23, one public hospital and one private hospital. Then I went a period to the United States for observerships, and then I met Dr. Prevedelo. I spent there 6 months at the Ohio State University, where I had the opportunity to watch surgeries and work in the lab. In the middle of 2016, I was back in Belo Horizonte, and I started working in these hospitals. So here in Brazil, in general, we work in more than one hospital. We do not receive salaries, monthly salaries. I get paid by production. So most neurosurgeons work in more than one center. I work in 3 private hospitals where I have one reality, and in one public hospital, the reality is totally different, where I do not have resources for more complex cases. This is our experience. So I work here with neuro-oncology and skull-based surgery. I want the goal here would be to talk about endoscopic skull-based cases. This is half of my work here. And I would say that, so we work with gliomas, metastasis, meningiomas, the skull-based meningiomas, the vestibular schwannomas. But for those cases, for microneurosurgery, there are more people working here. So I'm in a good center in Brazil with experienced people working with these cases. But this is my opinion. We still have a few people working, trained working with endoscopic skull base. So in endoscopic skull bases, this is our cases in the last 8 years. 390 cases, 2/3 of them are pituitary adenomas. And this will be my focus today, to talk about pituitary adenomas and how this can help in the meaning of global neurosurgery. I came from a service where the most experienced neurosurgeon performed more than 800 pituitary cases by microsurgery, transsphenoidal microsurgery. And now we are in our learning curve with these 390 cases. And why to talk about pituitary adenomas? Everybody knows a little bit the Lancet Commission recommendations from 2015. Then we have this article from Dr. Dewan and colleagues. They estimate the demand of essential neurosurgical procedures per year, and it's about 13 million, almost 14 million procedures per year. And we have in first traumatic brain injuries, then stroke, epilepsy, hydrocephalus, and then brain tumors, about more than 700,000 cases per year. And when we see the demand of the cases that are not performed per year, it's almost half of those cases, more than 5 million cases per year. And what's the role of neurosurgery for brain tumors? We have a special interest in benign brain tumors. Why? Because for these cases, we just need surgery. So if we have a structure and if we have training for surgery, probably the patient will not need chemotherapy, radiotherapy, other expensive things. So when we talk about global neurosurgery, of course, we want to treat all the patients. All the patients are important. But when we are treating benign tumors, we can be more cost effective. We are returning with young people generally that can make difference in the economic of that country. So when we talk about benign pituitary tumors, we have first meningiomas and then pituitary adenomas in frequency. And why we are going to talk about pituitary tumors? I told before, there are a lot of people working, there are more neurosurgeons here working with meningiomas, with gliomas, and few people working with endoscopic skull-based surgery. So for me, the most common pathology I treat is pituitary tumors, and sometimes we receive friends from colleagues from other countries, other regions from Brazil, and we see that there are few people trained for these cases. Most of the time, there are people with structure, but they stop trying to perform the cases because of training. So the first challenge is to learn how to follow surgical principles for pituitary tumors. So when we have pituitary tumor, what we want to do? First, the reduction of mass effect. We need to preserve or restore the normal neurological functions, and we need to decompress the gland to improve or to maintain residual hormonal function. But also, I would put another thing we always try to do, that is total resection. So this paper from 2014 from group of from Cornell, they show that the quality of life of the patients is better when we achieve total removal. Of course, this is not always the case, but this is something we always try to do. I will put a few examples. I'm not going to talk about technical aspects of pituitary tumors, but just to understand what is our concern here. This is a normal pituitary tumor, a big pituitary tumor, 3 centimeters, normal case. So you can use different instruments. Here we are using a curette and a suction, and diaphragm goes down, and the tumor is soft. This is a normal case. Most common cases are like this. And okay, if we have cases like this all the time, it would be easier to understand training. So this post-op. Another case, so there will be a few cases just to understand how we can improve our technique. This case, we are going to let's put more in front. we try to dissect the pituitary capsule, pseudocapsule. So this is something we always try to do for small tumors. When we have bigger tumors, we try to find the gland, and even we remove it in pieces. We try to get that plane between the gland and tumor and do the extracapsular dissection, so to preserve the gland and have better outcomes. Sometimes we have cases like this. This is a fibrous adenoma. 7% of the cases are like this, and these are the cases where someone with less experience would leave a lot of tumor, and this is what we are trying to improve in our learning curve and work extracapsular for cases like this. Let me pass a little bit. In the case like this, we can remove all the tumor. Patient is probably cured from his disease. Gland is there. So pass. Are you hearing me? I'm trying to pass the video, but
yeah, we can hear you, Lucas. We see the imaging with the with the MRI on the right side, and the video is going a little slow, but we can see it.
Okay, it's just running here. Okay, I have another 2 videos. I'm not sure if they're going to pass. So this is adenoma, GH adenoma with cavernous sinus invasion. So just to show for cases like this, we have to try to cure the patient and enter the cavernous sinus. The same thing we work here is carotid artery. We work extracapsular to try to remove all the tumor. I'll pass to the last case. So more complex cases. Here's a multilobulated adenoma with anterior extension to the third ventricle. And here we do a transplantal approach, like I learned from Dr. Prevedelo, and we start removing tumor in the 2nd floor when the tumor is soft. I will skip the video and go to the post-op.
Yeah, we see like
it's not working very well here.
We're not seeing the video itself, just random.
Okay. Okay, I'll try to skip it. It's loading. Sorry. Okay. So pre-op. Just a minute, not working. I'll stop sharing just for a minute. I'll put again. That's good. Okay. Now I see you. Just open again. I'll skip the videos.
Are you sharing now, Lucas?
No, not now. I'm opening again the keynote here.
The file.
Okay, so I put here. We are post-op of that case. And I'll stop. That was the last video. So yeah, I believe internet's not very good here. It stopped again. I'm not sharing, right?
Lucas, I think Rwanda's internet is better than Brazil's.
Yeah.
I think that has been clear in this session here.
I'll try. Just a minute.
I think I'm curious to see Mozambique's maybe better as well. Let's see. I'm curious.
Okay, Wi-Fi. Let me put here.
Yes, Dr. Lima, whatever you think is best. If there's I agree skipping the video may help with the stream. If there's any more still pictures or audio you want to go through, then happy to finish out whatever you think is the most critical information.
He's frozen. I'm wondering if it's not a bad idea to get Mikhail to talk, Said, maybe. Yeah. Lucas, what do you want to conclude, or you prefer to get Mikhail to talk, Lucas?
Yeah, let me try just once. Not working. Can you see my screen?
We can see now.
Yes.
Seems to be moving a little better.
Okay.
There were several portions where you were frozen, Lucas, so.
Let me see. If it's not working very well, I can just put in the other screen here. Maybe it will work better.
Seems to be working now.
Okay, so I'm not going to put the play here. This is one thing. First, the technical challenges of the surgery. The second challenge that we see here in South America is the language barrier. So my English is not very good, but the scenario is a little bit worse here. There are a lot of neurosurgeons that can read in English. So this is a concern for us, and because of these things, we decided to make this questionnaire and apply in the countries of Latin America, the 19 countries that are part of the FLUNC, and also in Portuguese and Spanish-speaking African countries. So we made this questionnaire with 50 questions related to neuroendoscopy, skull-based neuroendoscopy, and ventricular neuroendoscopy. This was last year during a 1-month period. So we included these 19 countries here with the red pins in Latin America, and also the 6 countries in Africa that speak Portuguese or Spanish. These were our responses, 202 responses, compared with other studies, a good number of responses with 104 cities in 18 from the 19 countries in Latin America. We just didn't have answer from El Salvador. And 4 of the 6 countries in Africa. The other 2 countries in that time didn't have neurosurgery services there. Guinea-Bissau and São Tomé e Príncipe. And what we found in this questionnaire is that about the structure, most hospitals have medical residency. Video and camera tower are very frequent. 88% of the hospitals of the users. Optics and instruments for ventricular or for skull-based surgery are also frequent, more than 6% and 7%. And adult ICU or pediatric ICU, most hospitals also have it. So specific about skull-based endoscopy, from those 202 answers, 145 responses, someone in the team performed endoscopic skull-based surgery. Most of the people work with pituitary tumors, CSF leak, and extended extradural approaches. Half work also with more challenging approaches, intradural approaches, transplant and transcribiform, or approaches in the coronal plane, or few places also work with vascular surgery. we try to split these two groups here. So we try to find places that could work with those more complex cases. We found 34 centers that also perform more than 48 cases per year. This is the number we decided to put 4 cases per month. Should be a good place to have training for our reality here. So from those 34 level A centers, so yellow pins are those level A centers with more than 48 cases. Blue pins, all the places that perform endoscopic skull-based surgery. I would show here in Africa, so we just have Angola of the 6 countries that perform some endoscopic skull-based surgeries, but a few cases, not too much. Only 7 places have laboratories for training, for research fellowship. And we had 34 centers, 12 offering additional training, and the other 22, they want to offer training, but today they don't do it. We have basically 2 branches of endoscope that dominate the market, Stores and Escolab, but we also had other 8 branches mentioned. And these are the places that do not perform any endoscopic endonasal approaches. So we found 57 answers from 50 hospitals in 43 cities. In purple pinks, we have hospitals where they do not perform endoscopic skull-based surgery, but there is other place in the region, other hospital in the region that could do it. And in red pins, we have places where people answered that there is no other center also performing endoscopic skull-based surgery. Once again, in Africa, we just have in Luanda, in Angola, other places performing endoscopic skull-based surgery. All the other countries, there is no endoscopic approaches. And we asked the reason for not performing the techniques, and basically we have 2 answers. First of all, is training. Most people do not have specifically trained, is not trained for these approaches. And then we have equipment. 42% of the centers, they answered that equipment is also a concern for these procedures. So to finish, I just want to discuss some topics and share some ideas we have here and projects we are trying to run. So first of all, observational and clinical fellowships. We need to have more of this, especially here in Latin America. So most neurosurgeons that want to train have to live here and go to United States, Canada, Europe. But I believe we have like some islands here of places with structure and training, big cities in the bigger countries, Brazil, Argentina, Colombia, Chile, with structure to perform challenging cases, but there is nothing to link these people. I put here Intersurgeon. I don't know if you know the website, but this is very interesting. It was created by pediatric neurosurgeons. It's a place where you can find people interested in training and people interested in offering training. As Claire said, here the anatomy laboratories are very few, so this is something we need to have more to create more centers, to have support for more centers, or to have facilities to go to other places. Yeah, we have today. We have after the COVID, we have a lot of webinars, but there are other forms of physical and virtual training modules, and I believe this is very good. The webinars are very good, but generally we are going to have 1 month of section of vascular neurosurgery, and then 1 month of skull-based neurosurgery. And what we are trying to do here, we are trying to organize a course. We are talking with one of the medical schools from here in Belo Horizonte that have a structure to conduct an online course, and we want to perform a course with lectures of endocrinology, ophthalmology, radiotherapy, neurosurgery, anatomy, everything, to have the whole team trained for these approaches, for initially for pituitary tumors, but also for other skull-based, more complex skull-based approaches. We are trying to organize this in Portuguese and in Spanish. So I wanted to do it for free, but there are the costs of the university. We are trying to do it for a low cost, so we can perform first a complete training of other neurosurgeons, and after that we can think in missions or other types of training. I put here something that Claire wrote. We cannot, it's not, in my opinion, like he said, we cannot just go for a place and with expensive instruments, with specific training, and perform some cases, and do not have trained people there. So, in my opinion, first we have more work to do before, and then we can go and lapidate the training of these people interested in training. And after that, there are other forms of continuity training, telemedicine, distance mentoring. This is Dr. Benjamin Worf with his project NeuroKids. He's doing this in Africa and also in Latin America. So other forms of treatment. We need support from the companies. This is from the website of World Federation. We have sponsors for some microsurgical instruments with Escolab. We have a sponsor for microscopes from Zeiss. We have a sponsor from high-speed drills, but there is nothing about endoscopic instruments and sets. So this is something the committees could work with too. And to finish, we need to work with public policy. We need to, my opinion, to build a consensus, issue statements, and make recommendations for the national societies and also for public ministries. Mikhail has some experience with this. Maybe he can talk about later. So that's it. That's my thoughts, and hope we can discuss and help to create something a little bit better. Thank you all for the attention. I'll stop sharing here.
That was wonderful, Dr. Lima. I really appreciate the extensive work